Hey guys, it's Jake here with Med School Bootcamp. Thanks for tuning into another video. Today we're going to be talking about skin structure and function. Go ahead and take a look at the outline above and let's get busy. So first, let's talk about the structure and function of our skin. Why do we have skin? It's basically a giant protective coating from our scary environment. Our environment has viruses and bacteria and UV radiation and anything else that's just trying to get inside of our body and make us sick. Our skin protects us from all of those things. So I'm going to highlight some of the things it protects us from, and also note that it is a self-healing organ. So when it does sustain damage, it repairs itself. Now, our skin is made of two main layers, the epidermis, which is derived from ectoderm, and the dermis, which is derived from mesoderm. Below those two layers is a layer called the hypodermis. Now, this is technically not skin, but I wanted to include it to give you guys some perspective. Now I want to draw a little bit to show these layers on my diagram. So everywhere below what I have in pink is going to be dermis. Everything above my pink is going to be epidermis. Over here below my green is going to be hypodermis, which is going to be made primarily of fat. So we've overviewed the basic layers. Let's get in depth a little bit more about each one. So let's start off with talking about the epidermis. When we talk about this, I want you guys to think of Army boot camp, okay? And in Army boot camp, we hire recruits. These recruits are going to be our keratinocytes. They're structural cells filled with keratin, which is a protective molecule. These recruits begin in the stratum basale, which is the deepest layer of the epidermis. It's actually a stem cell population, so it is where these recruits are born. Then they're going to move from deep to superficial, all the way up to the stratum corneum, where they eventually will protect us from our environment. Along the way, they're going to pass through the stratum spinosum, which is heavy in desmosomes, the stratum granulosum, which they will acquire granules, stratum lucidum, they will subsequently lose those granules, and finally in the stratum corneum, they will be anuclear cells, which are technically dead. So our recruits at this point are dead on the battlefield, but their keratin sacs are protecting us from everything out there in the environment. Now, there are a few other functions of the epidermis and some specialized cells. These are Langerhans cells, Merkel cells, and melanocytes, and they are responsible for things like producing pigment and helping us with sensation and also some immune function. Now, I want to give you guys a great mnemonic for remembering these layers. It's called Come, Let's Get Sunburned. This mnemonic, the first letters of each word correspond to the first letters of each layer of the epidermis. It's a great way to remember these. Next, let's talk about the dermis, which is the layer just deep to the epidermis. It's split into two layers, the reticular dermis, which is on the bottom, and the papillary dermis, which is on the top. The papillary dermis is a very dynamic structure, whereas the reticular dermis is a lot more structural and supportive. So when we're talking about the papillary dermis, I like to think of her as the skinny legend. She is thin, but she does a lot. And she has these cool things called Reedy's ridges. These are especially important with certain pathologies where these Reedy's ridges will change in their character. And we'll talk about that in subsequent videos. So here, if we look, this pink represents the thin papillary dermis, and this pink represents the thick reticular dermis. So I want to highlight for you here, all these structures are in reticular dermis in green, and in orange, these are all going to be papillary dermis. You'll note that capillaries is actually present twice, and that's to give you guys the theme that everything that begins in the reticular dermis will eventually course upwards through the papillary dermis as it makes its way to the skin surface. Now let's talk about some of the junctions that connect all the epithelial cells within our skin layers. So I like to have a metaphor called the jacket metaphor. So here's Jakey wearing his jacket, okay? There's my arms, there's my head, and this is cell number 1. And this is cell number 2. Now, jackets, cell number 1, cell number 2, need to be closed. And these closures of our jacket, whether it's zippers or Velcro or buttons or ties, are going to represent the different cellular connections we have. So let's start off by talking about tight junctions. Tight junctions, which I'm circling here, are analogous to cellular zippers. They are extremely tight junctions, so tight that they prevent the transit between cells of ions, metabolites, and other things like neurotransmitters. Now, these are so tight that they are very useful in places like the blood-brain barrier and the blood-testes barrier, where we need to prevent paracellular transit. Super important to be aware of this on test day. Now, these tight junctions are going to be made of claudins and occludins. These are hot words to know when talking about tight junctions. Next, let's talk about adherence junctions, which are like the Velcro of our cells. So, Velcro is very dynamic, much quicker on off than a zipper, but not quite as tight. So I'm drawing some cells here, and then I'm going to have our adherence junctions connecting all of the cells. And this adherence junctions connect cells via actin. So now I'm going to draw in actin filaments all the way across. Okay? These actin filaments span all the cells and create belt-like structures. That's an important hot word when we're talking about adherence junctions. Now, these are very dynamic because they are composed of E-cadherin, which are calcium-dependent connecting proteins. They can change really rapidly, so we can have connection or we can have disconnection when we need it. This is really important in things like development, where we have a lot of transposition of cells back and forth, and also in malignancy, where we have loss of cadherin and cells can be flicked off really easily and become malignant. So that is something to be aware of. Here in our diagram, I'm going to circle. This is the Velcro-like connection between two epithelial cells. Next, let's talk about desmosomes, which are going to be like the buttons of our jacket. Buttons I like to think of as really strong, but not so close together. So they allow a lot of things to pass in and out, but they are very strong. So think of desmosomes as all about structural support. And this can be explained by the fact that they are connected to intermediate filaments instead of actin. Intermediate filaments are really thick, whereas actin is very thin and a lot more dynamic. These desmosomes are made of desmoplakin, desmocollin, but most importantly, desmogliin. Now, desmogliin 1 is a specific protein implicated in disease. In pemphigus vulgaris, there's autoimmune attack of desmogliin 1, whereas in staphylococcal scalded skin syndrome and bullous impetigo, we have the production of an exotoxin that attacks desmogliin 1. Together, these pathologies all attack our desmosome and cause skin to split, and this causes blistering pathologies. Now, hemidesmosomes are like a half of a desmosome, so we still have our buttons, really strong, connected to intermediate filaments, but now, instead of connecting two adjacent epithelial cells, we are now connecting an epithelial cell to the basement membrane. So, the support function is still the same, it's just a matter of location. So let's talk about how these are a little different in terms of composition. Since we are connecting to the basement membrane, integrins are going to be an important part that are in hemidesmosome but not in desmosome. Also, on the cellular side, we're going to have laminin 5 and intermediate filaments, just like a desmosome, but on the extracellular side, we're going to be dealing with type 4 collagen. So that's just a little bit of composition variation between desmosome and hemidesmosome. In terms of pathology, hemidesmosomes are associated with bullous pemphigoid. That is the one disease to be aware of here. Lastly, let's talk about gap junctions, which I like to think of as the porous holes within our jacket itself. When they say that a jacket breathes like Egyptian cotton, I think of gap junctions. And that's because they facilitate electrochemical communication. So think small ions and neurotransmitters. So electrochemical communication is key for gap junctions. Now, these are made of 6-part proteins called connexons, and they kind of assemble like so. And these neurotransmitters and small ions will move through these connexons. Now, we know that the heart is a giant muscle full of electrochemical communication. This is where there are a lot of gap junctions, and when we have pathology here, it can lead to arrhythmias. I'm going to go ahead and circle our gap junction here in our diagram, and just remember, this is key for cellular communication. Let's do some quick summarization of our metaphor. We started out by talking about tight junctions, which are the tightest possible connection we talked about today, analogous to a zipper. And then we moved on to adherence junctions, which are a much more dynamic structural support made of actin-actin communication. Then we talked about desmosomes and hemidesmosomes, which also provide structural support, but it's much stronger because we're connected via intermediate filaments. Lastly, we talked about gap junctions, which are made of connexins, and are responsible for electrochemical communication. I advise you guys use this table to organize your thoughts, and I would use spaced repetition to help remember these alternative names as well as the composition. That's it for our video on skin structure and function, guys. I really hope you guys enjoyed it. Can't wait to see you guys in the next video. Remember, the best way to do well on step 1 is to stay busy. So I will see you in the next one. Bye! Hey guys, it's Jake here. Thanks for tuning in to another video. Today we're going to be talking about histopathology, so go ahead and take a look at the outline above, and let's get busy. First, let's talk about hyperkeratosis, which is going to be increased thickening of the stratum corneum, which is going to be the most superficial layer of the epidermis. Let's outline that here in our picture here. So this is a normal stratum corneum, and then over here, we have a very thickened, increased stratum corneum of a verruca. Here's another example over here. This wart has an extremely thick stratum corneum. We're going to see this in disease processes like calluses, psoriasis, verruca, and even cancerous scale. So be on the lookout for a very large stratum corneum, and that's going to be associated with very dry and crusty lesions. Now let's talk about parakeratosis, which is retention of nuclei within the stratum corneum. Now remember, the stratum corneum, which I'm labeling here, is usually an anucleated cellular layer. But if we look, there are nuclei all throughout this stratum corneum, which is not a normal finding. You can see here in this larger picture that there are tons of nuclei all along this layer of the stratum corneum. This is not normal. We're going to see this in disease processes like psoriasis and actinic keratoses. I've labeled actinic keratosis here for this hand, and then this beefy red plaque is an example of psoriasis. Both of these will have parakeratosis. Let's touch on hypergranulosis, which is going to be increased thickening of the stratum granulosum. You're going to see this disease process occur in lichen planus. Let's first draw out what hypergranulosis looks like. So I'm going to trace here right under stratum corneum, the stratum corneum being bright pink and the granulosum layer being darker purple. You'll see that the stratum granulosum is nearly double the size of the stratum corneum here, which is not a normal finding. You're going to find this in lichen planus. Now, lichen planus can also present as Wickman striae, which are these reticular lacy white findings in the oral mucosa. So also be on the lookout for that. Lichen planus is classically described by the 6 P's, which I'm going to write out for you guys because they're really important and it's a great mnemonic. If you can remember purple, peritic, polygonar, planar, papules, and plaques, that is a great way to recognize lichen planus on the exam, and remember it's accompanied by hypergranulosis. Next, we'll talk about spongiosis, which is going to be accumulation of fluid within intercellular spaces of the epidermis. So intercellular here, not within cells, but between cells. You're going to see this in atopic dermatitis and also allergic contact dermatitis. So you're going to see spongiosis in lesions that are described as like urticaria or wheals or hives. And you'll see that this is characterized by this accumulation of white fluid in the epidermal layers. This is going to look like the urticarial rash here seen on physical exam, and it's a great way to describe this finding histologically. Acanthosis is going to be thickening of the stratum spinosum. We're going to classically see this in acanthosis nigricans, which is going to be a disease process that characterizes insulin resistance. People with metabolic syndrome, they're going to get these dark-like features on their skin, especially in the skin folds like the axilla and the neck. This is called acanthosis nigricans. In the histology, you can see that the stratum spinosum, which is this darker purple layer, is really, really thick in a lot of places, and that is what characterizes acanthosis. Lastly, let's touch on acantholysis, which is going to be separation of layers of the epidermis, especially the stratum spinosum, which is a desmosome-heavy layer. Remember, desmosomes are made up of desmoglein 1. Now, there are 2 disease processes in step 1 that attack desmoglein 1. The first is going to be autoimmune via production of antibodies. These antibodies directly target desmoglein 1 and destroy it. Now, on the flip side of the coin, there are 2 infectious processes that also target desmoglein 1. This is via production of an exotoxin. This exotoxin targets desmoglein 1 and destroys it. So remember, there's an autoimmune way and an infectious way to destroy desmoglein 1, the end result is going to be the same, which is acantholysis. Now, acantholysis is characterized by these floating keratinocytes. So you see, this is a big blister of white fluid. There are floating keratinocytes inside. Also, there's going to be something called tombstoning. I'm going to zoom in for you on these keratinocytes. They look like this. They look like tombstones in a cemetery. At the cellular level, these would probably look more like this. Now, this is caused because the keratinocytes, their brothers and sisters, literally get ripped off the roof of them. So you can imagine they used to have brothers and sisters on top of them, but when this blister formed because of destruction of desmoglein 1, these get ripped away and it leaves these tombstones. So I like to think RIP, really sad. That's blistering disease for you. But anyways, acantholysis is going to be characterized by these tombstoning, floating keratinocytes, and it's also going to be Nikolsky sign positive. Now, things are Nikolsky sign positive when we have separation of individual layers of the epidermis without basement membrane involvement. So that's key. No basement membrane involvement here. Now, let's describe what Nikolsky sign positive looks like clinically. So if we look at this picture of pemphigus vulgaris in this gentleman here, you can see that he has blisters that have all sloughed off. They have opened up very easily. These blisters will open at the slightest touch of a finger, and that is what characterizes Nikolsky sign positive, and the histological description of that is going to be acantholysis. Here's a table summarizing all the histopathological changes we talked about today. I want you guys to pay careful attention to all the buzz pathologies associated with each cellular change. I also want you guys to be aware of the great mimic, which is psoriasis. It can present as hyperkeratosis, parakeratosis, or as acanthosis. So it's really important to be aware of each of those changes associated with psoriasis. That's it for our video on histopathological changes. I hope you guys enjoyed it. Remember, the best way to do well on step 1 is to stay busy. Can't wait to see you guys in the next video. Hey guys, it's Jake here with Med School Bootcamp. Thanks for tuning in to another video. Today we're going to be talking all about skin lesions. Go ahead and take a look at the outline above. One thing to note, in terms of our differential diagnoses today, these lists are not going to be exhaustive. There are so many diagnoses associated with each of these lesions. I'm just going to cover a couple of high-yield differentials for you to have a working vocabulary to talk about these lesions on step 1. So without further ado, let's get busy. So we're going to start off by talking about macules, which are flat lesions that are discolored from surrounding skin. These can either be hyperpigmented, meaning they are darker than surrounding skin, or hypopigmented, meaning they're lighter than surrounding skin. Importantly about macules, these are going to be less than or equal to 1 centimeter in diameter, and they are flat. So if I were to rub my hand over my face and feel for a macule, I wouldn't be able to feel it because they are not raised. They are completely flat. So let's look at some differential diagnoses. We have freckles, solar lentigos, tinea versicolor. Here on this arm, we have an example of a solar lentigo. It is less than or equal to 1 centimeter, but is a flat, discolored lesion. This happens to be a hyperpigmented lesion because it's darker than surrounding skin. There are also some hyperpigmented freckles around this large solar lentigo. These also count as macules. Next, let's talk about a patch, which is essentially a large macule greater than or equal to 1 centimeter in diameter. These are also flat. Classic examples of this are going to be birthmarks, such as port wine stain. We can see on the back of this person's calf, they have a very large port wine stain, much larger than 1 centimeter, which is why this classifies as a patch. Patches are going to also be superficial epidermal structures, just like macules. Next, let's talk about papules, which are going to be raised lesions. If I was to rub my hand over my face, I would easily be able to feel a papule because it's elevated. Importantly, these are going to be less than or equal to 1 centimeter in diameter. A classic example here, we have some papules on the arm, and these are umbilicated papules, which is characteristic of molluscum contagiosum. What do I mean by umbilicated? This papule will have a central depression within it that counts as an umbilicated papule, whereas other papules, such as those found in acne, will not be umbilicated. This is just an example. There are many diseases that can cause papules. Next, we'll talk about plaques, which are going to be raised lesions that are greater than or equal to 1 centimeter in diameter. Classic example of a plaque on step 1 is going to be psoriasis. This is going to be a raised erythematous beefy plaque. This is a great example of a psoriatic plaque on someone's elbow. Another classic disease process that is often described as a plaque is going to be basal cell carcinoma when it gets larger than 1 centimeter in diameter. Next, let's talk about vesicles, which are going to be fluid-filled blisters that are less than or equal to 1 centimeter in diameter. These vesicles can be Nikolsky sign negative or positive. Let's talk about what that means because it's important. So, here's my skin, and here's my overlying blister filled with fluid. If I were to take a gloved finger and apply slight pressure to that blister, and it were to burst open and release all of its contents out like so, that counts as being Nikolsky sign positive. If I were to apply that slight pressure and the blister was to maintain its integrity, that's Nikolsky sign negative. And this is an important way to describe vesicles because it can help us narrow down pathologies. So I want to highlight it for you guys. It's important to know. This vesicle description that we have here is going to be a herpetic lesion. These are classically defined as dewdrop on a rose petal, which roughly translates to clear vesicles on top of an erythematous base. These are going to be the classic lesions you'll see in varicella zoster and herpes simplex. Now we'll talk about bullae, which are essentially large vesicles greater than or equal to 1 centimeter. They also can be Nikolsky sign positive or negative, and instead of being associated with the herpetic lesions, we usually use bullae to describe the larger blistering diseases like pemphigus vulgaris, bullous pemphigoid, and also major burns that lead to blistering. Now we will talk about pustules, which are going to be pus-filled vesicles. So they're going to be less than or equal to 1 centimeter, but instead of clear fluid, now we have pus. Here in this picture is an example of folliculitis. You'll notice that there are a lot of pustules, and each one is associated with an individual hair follicle. A classic example of this is hot tub folliculitis caused by Pseudomonas, so be on the lookout for that diagnosis. You can also have pustules associated with acne. So acne can cause papules or it can cause pustules, just depending on the characteristic of the lesion. So let's talk about wheals, which are going to be raised papules or plaques, but these are characterized by significant edema and their pink color. These lesions are going to be more transient than the lesions we talked about previously. Wheals are around for the order of minutes to hours, whereas papules and plaques are around for days to weeks. Let's talk about what makes wheals so transient, and the answer comes with IgE and histamine, which are the mediators of wheals. So when you have an allergic reaction, you have IgE and histamine released, and that causes local release of fluid within the epidermis. You'll notice that all of the wheal is made within the epidermis, whereas other types of edema, like pitting edema from heart failure, is going to be located much lower, down here in the hypodermis. So I hope that explains to you guys why wheals have this pink, pruritic, kind of transient nature to them. Some great examples are all going to be allergy related. So like think allergic contact dermatitis, which we can see here with this L503 that someone literally carved into their skin with something they were allergic to, or hives and insect stings and bites. Next, guys, let's talk about scale, which is going to be caused by a thickened stratum corneum. You'll remember that we have many layers of skin, but the stratum corneum gets really overgrown in the case of scale. This thickened stratum corneum is characterized by dry, flaky, and white and silver residue. So if we look at this person's hand, they actually have actinic keratoses from years of sun damage, and you'll see they have this really flaky white scale on the tops of their hands, and that's from a thickened stratum corneum. You can also see this in psoriasis and also in eczema. We mentioned actinic keratosis, and that can eventually change into squamous cell carcinoma. Now let's talk about crust and how we can differentiate it from scale. So remember, scale is a thickened stratum corneum, so that's going to just be dry excess keratinocytes, whereas crust is made from secretions that were once moist and are now dry. So think about serosanguinous fluid or blood or pus that is now dried up. Just like if you were to leave honey, which is originally a liquid, out on the counter, it will dry up and become crusty. And that's exactly what we see here in this lesion of impetigo, classically described as honey-colored crusting. Some other examples of crust would be atopic dermatitis and also scab formation, which is just blood that has now become a crust. Next, let's talk about excoriation, which is literally just a fancy word for scratching. So it's abrasions due to mechanical force, and you will classically hear step one describe excoriation for someone who has excessive scratching due to some other disease or from trauma. That brings us to lichenification, which is going to be due to excoriation over a long period of time. So people who are scratching and scratching and scratching get skin that is really thick with accentuation of the skin markings. This is a classic description of lichenification. And lichenification is pretty nonspecific. Even the term lichen simplex chronicus just means that there's something going on that is causing this person's skin to be irritated over a long period of time. And we'll see here there's an example of this person's skin. You can see these accelerated, accentuated skin markings up here and this excessive dryness. This is exactly what lichenification will look like on exam. Next, let's talk about hematomas, which are going to be non-blanching collections of blood that are usually purple, pink, red, or even yellow-brown in color, depending on the age of the lesion and the location that it's in. So, let's talk about what it means to be non-blanching, because this is important. An example of blanching is cap refill. So when we press on our fingertips, we expect some pallor to occur because we have occluded blood supply from our fingers for a moment. That's an example of blanching. Hematomas are non-blanching. And why is that? It's because there is some sort of vascular damage that occurs in hematomas, causing blood to leak out of the vessels and stay in the interstitial space. So pressure will not change the color because the blood is going to sit there in no matter what. So let's talk about how we can kind of differentiate different hematomas. So when the hematomas are flat, aka non-palpable, we call them petechiae when they're small and ecchymoses when they're large. So we have example of a large ecchymoses here on this person's elbow. You can see that the color can be purple, but it can also be kind of yellow, brown, or pink. And then we have smaller petechiae, which are classically like pink, purple, or red. They are small, little hematomas that are still flat. We also have purpura, which are going to be raised lesions or palpable lesions. Example of that is here in the center of this person's ankle. These are going to be raised hematomas and they qualify as purpura. There are a variety of diseases that can cause petechiae, purpura, ecchymoses, and anything in between. So let's just go over a few. A classic cause of petechiae is going to be Neisseria meningitidis. A classic cause of ecchymoses is like a traumatic bruise like we saw here. And then classically the vasculitides can cause palpable purpura. A good example is IgA vasculitis. So be on the lookout for broad differentials associated with purpura, petechiae, and ecchymoses. That's it for our episode on skin lesions, guys. I hope you enjoyed it. Remember, the best way to do well on step 1 is to stay busy. Can't wait to see you guys in the next video. Bye! Hey guys, it's Jake here with Med School Bootcamp. Thanks for tuning in to another video. So here we're going to be talking all about bacterial infectious conditions of the skin. So go ahead and take a look at the outline over here and let's get busy. Let's start off by talking about impetigo, which is going to be a very common skin infection of our pediatric population. And I want to just start out by noting that there's two types, and I want to point these out to you on physical exam. So here I'm going to be outlining what we call superficial impetigo, and this is characterized by like a super crusty, golden, honey-colored scale. And so when you hear that honey-colored scale description, this honey-colored crusted skin lesion, that is a really hot buzzword for superficial impetigo, as opposed to bullous impetigo, which is going to be consisted of fluid-filled blisters. So if we look at the picture below superficial impetigo, we'll see that bullous impetigo is defined by these bullous structures that clearly look like blisters. And so that's how you're going to differentiate these two on physical exam. In terms of the microbiology of superficial impetigo is usually going to be caused by Staph aureus or Strep pyogenes. Whereas when we're talking about bullous impetigo, we're going to be looking more at Staph aureus as opposed to strep. So that's how you can kind of differentiate these based on microbiology. Treatment is really important because this is a really infectious condition, but also treating also helps us prevent rheumatic fever, which I'm going to highlight in green because it can be prevented with our antimicrobial therapy. Whereas post-strep glomerulonephritis cannot be prevented with antibiotics, and it is a sequelae of our strep infections like superficial impetigo. I want to talk about some of the pathophysiology that leads to this differential physical exam finding. So when we talk about bullous and impetigo, these are blisters that are going to be formed because of an exfoliative toxin that is produced by Staph aureus. And this exfoliative toxin is going to cleave desmoglein 1, which is found within the stratum granulosum. So this is going to lead to stratum granulosum cleavage, leading to blisters. So if I kind of model this for you guys here, I'm going to use like this bright green ink because it shows up nicely. Here's the stratum granulosum. You can imagine desmosomes all throughout here. And this exfoliative toxin, which I'm going to make here in red, comes through and it basically cleaves these desmosomes and it leads to blistering pathology. And that's what's going to lead to Nikolsky sign positive blisters. So let's talk about what Nikolsky sign positive means. So if this is the surface of the skin here, and then we have a blister right up here with some fluid inside, a Nikolsky sign positive blister is going to break open at the slightest amount of trauma. So if I just like to poke, 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 tap, tap, tap with my finger here on this blister, it would lyse open very easily and spill out all of its liquid. It sloughs off very easily. And this is what is characteristic of a Nikolsky sign positive lesion. So I'm just going to highlight that for you guys here, Nikolsky sign positive. Whereas our superficial impetigo infections are going to be Nikolsky sign negative and are going to be characterized by this crusty yellow scale instead. Let's move on to talk about scarlet fever, which is going to be another complication of group A strep infections. But in this case, it starts out as an erythematous rash that is kind of maculopapular and described as a sandpapery texture. That's really important. So a fine scarlet colored erythematous rash with sandpaper texture. I'm going to like triple highlight sandpaper because that's how important it is. And this rash will start along the face. So you'll notice here in this child here, we have a facial rash. So the rash starts here on the face and then it will spread down to the trunk and then the arms and the other extremities. But it's always going to be more significant on the face. You'll also notice that around the face, we have something called oral circumferential pallor. So right around this baby's face, you can see that there is some pallor here because the rash kind of avoids the area around the mouth. That's a pretty high yield physical exam finding for this rash. Additionally, the presence of pastilla lines, which are going to be areas of red in the creases of the elbow and the wrist, that is also a key physical exam finding to note here. So let's just go ahead and recap all of that. We have a rash that begins on the face and neck, then moves to trunk and extremities, oral circumferential pallor, along with pastilla lines. Now, I'm going to hit you guys with probably the hardest hitting fact of this entire disease process, which is going to be a strawberry tongue. So I'm going to outline this tongue here. And you'll notice I'm going to draw a stem, and these little pock-like marks here look like a strawberry. And this tongue is a classic example of strawberry tongue. This is a very high yield finding for scarlet fever. I'm going to have it in pink for you guys because it's probably the most high yield thing. We already talked about the microbiology, how this is caused by group strep A infections, and specifically it's going to be caused by an erythrogenic toxin. So this is what mediates all of these dermatologic findings. The treatment for this is going to be penicillin, and this is important because it's going to prevent rheumatic fever, just like we were talking about before with our superficial impetigo infections. It's really important to differentiate this from Kawasaki disease, which has a lot of the same presenting symptoms in terms of rash and oral involvement, but we will go over the specifics of Kawasaki disease and the mnemonic crash and burn in a later video. I just want to have you guys on the radar when we're talking about children with febrile illness and rash. Next, let's talk about cellulitis. And when we're talking about cellulitis, I want you guys to focus on two key things. And that's going to be the depth of the infection and also the physical exam findings, specifically the border of the rash. And that is going to be the key differentiating factors here for cellulitis. So let's talk about the depth of the infection. So in cellulitis infections, we are going to be infecting the deep dermis layers. And what happens is we have some sort of superficial trauma up at the top here near the stratum corneum. This could be a bug bite, this could be a sting, this could be a nick, this could be a little scratch. Just about anything that breaks the surface of the skin is going to allow bacteria to seed. And what happens is that bacteria moves all the way down to this dermal layer, and that's where it infects. And that's key because they like to ask about the layer that is infected. So I'm going to highlight that for you here, deep dermal and subcutaneous tissue infection. That is key. Now, let's look at the important physical exam findings. You'll see that this is like an erythematous pink rash, right? Which could describe a lot of rashes. But what's important here is if we look at the border is kind of diffuse. It's kind of hard to mark out where the cellulitis infection is, so much so that this astute medical student drew up with a marker to show the border of the rash to see if there was any progression. Additionally, This can be characterized by streaking. If you see individualized lines of erythema going up towards the lymph node, that's highly characteristic of cellulitis. So I'm going to put here that we have streaking of erythema, and then we also have poorly defined borders. And then our lower extremities are going to be classic, and also our hands as well, because these are areas of trauma. So you're banging your lower extremities around when you're walking, and you're always doing things with your hands, which allows bacteria to seed much more easily. In terms of the bugs, we have two different types. So non-purulent cellulitis is classically going to be caused by beta-hemolytic strep pyogenes, whereas our purulent strep is going to be caused usually by Staph aureus. Now, the picture here that I showed is a picture of the non-purulent type, whereas the purulent type will look kind of similar, but it will have induration and fluctuates. So like a little lake or some fluid that you would be able to tap on and feel underneath that area of erythema. In terms of our management of this, we are just going to give antibiotics that are going to cover the bug we suspect. So it'll be a great choice to choose something that covers both staph and strep. In terms of our differential, we have erysipelas as the main differential here. And the key here, like I said before, is all about the borders of the rash. So in cellulitis, the borders are not well defined, whereas in erysipelas, which we'll see next, the borders are very well defined, and you will really appreciate this. So here we are, erysipelas. I'll just hit it straight into the borders. So I'm going to trace around these borders of this rash. You'll note that this rash is like much more purple and beefy and red than like the previously like salmon erythema of cellulitis. And these borders of this rash are just like super well defined. And this has to do with the layer of infection that happens. So just like in cellulitis, we have some sort of superficial nick or trauma or sting that seeds bacteria. However, in this case, the bacteria is going to go only to the superficial dermis. So like right here along the papillary dermis, right where the dermis meets the epidermis, that's the area of this infection. So I'm going to highlight in this darker purple color because it reminds me of erysipelas. So we have superficial dermis infection this time. Just like in cellulitis, the lower extremities are common, but also here, the face is going to be super common. So if you see someone with a face like this, that is really going to be highlighting for you erysipelas, especially if we note systemic symptoms. So like fever, tachycardia, those are also going to be a helpful hint that this is an erysipelas infection, as opposed to maybe a malar rash from like lupus or rosacea. And I just want to touch that cellulitis is also going to have these systemic symptoms like tachycardia and fever as well. And it's just a signal that this infection is getting really bad and kind of moving systemically and getting your body ramped up to fight. So in terms of the bug here for erysipelas, it's going to be strep pyogenes in most cases. So that's just one bug you have to memorize for this one. Antibiotics are going to be anything that covers strep that is tolerable by the patient. And in terms of our differential, it's going to be cellulitis, which we talked about before. So I'll highlight it in red because that's what we were talking about. And we do that by looking at the borders and the color. So cellulitis, salmon, lighter erythema, whereas erysipelas is going to be much darker purple, and it's going to have extremely well-defined borders. So here we can look at a comparison table looking at the two disease processes. And let's just start with our borders. So you'll see here in erysipelas, super well-defined. We love to see it. Whereas in cellulitis, it's a little bit harder to delineate this border, and you may get a clue about some streaking erythema moving up towards the lymph node. Also, super important for test day is they will like to ask you about the layer affected. So in our cellulitis infections, we are looking at the deep dermal structures, whereas our erysipelas infections, we are looking at the superficial papillary dermis right along the epidermal border. Those are going to be some key facts. Here is a table. This is going to summarize all the things we just talked about. So things I want to point out for erysipelas is that it is going to be a superficial dermis infection. It has clear demarcations, and the face is going to be a really common spot. Whereas for cellulitis, it is going to be a deep dermis infection due to possibly two bugs, and it's going to be a poorly defined rash, and it is classically going to be on the lower extremities. Next, let's talk about staphylococcal scalded skin syndrome, which is going to be a generalized staph infection of the entire epidermis. And this comes with some pretty high yield facts, and it's very similar to bullous impetigo, which we talked about in the beginning. So same exact mechanism as bullous impetigo, which earlier I highlighted in blue. So I'm going to highlight in turquoise here to keep you guys kind of in the same wavelength. So if we review that mechanism, we have an exfoliative toxin that cleaves desiccating 1, leading to stratum granulosum cleavage and blisters. So just to recap, we have stratum granulosum, which is right between this green area that I'm going to be highlighting here. And we have a lot of desmosomes in this area. And the desmoglein one of these desmosomes is killed by the exfoliative toxin, and that leads to Nikolsky sign positive blisters, which you guys will remember are when we barely tap on the blister and it sloughs open and it basically erupts. So you'll notice here on this little baby that there is this humongous blister out on his hand, and it's just like completely sloughed open because it's Nikolsky sign positive. So this blistering pathology will be on the entirety of this baby's epidermis. And this is really common in babies and children, also in adults with renal insufficiency. And this is all because of the exfoliative toxin. So in the babies and the kids, their immune systems are not good enough to fight off the toxin. So that's why they get this. In adults with renal insufficiency, their kidneys cannot filter out the toxins, so it accumulates in their body, and that's what leads to this pathology for them. In terms of the microbiology, it's going to be due to Staph aureus, and this is very similar to the bolus impetigo that we talked about, the fact that this creates the exfoliative toxin. That is the whole crux of this disease process. Now, important is differentiating this from SJS, which is Stevens-Johnson syndrome. Now, in terms of history, Stevens-Johnson syndrome is usually going to be associated with the commencement of a new drug, whereas this staphylococcal scalded skin syndrome is going to be due to an infection with Staph aureus. Additionally, Staph aureus mediated staphylococcal scalded skin syndrome is not going to have any oral involvement. So if you ask this patient to open their mouth and you look inside, there's going to be no blisters. They're going to have a normal looking oral exam. However, in Stevens-Johnson syndrome, they will have oral involvement most of the time. So a good way to differentiate is that there is no mucosal involvement when we are talking about staphylococcal scalded skin syndrome. I want to mention that this disease process, even though it is horrible, it heals completely without any scarring. And that's because this is an infection that is solely limited to the epidermis. And the epidermis can take a lot of damage before it results in scarring. So a lot of times test questions will ask the prognosis of this disease process. And if they're given appropriate antibiotic therapy, these babies and these children are going to heal with perfectly normal skin in adulthood. Next, I want to talk about abscess, which is pretty straightforward on the step one exam. It is a collection of pus in the dermis and epidermis, and it's almost always going to be due to Staph aureus. And that's pretty high yield in terms of these abscess infections. These abscesses, you're going to be able to tap on them and feel like a lake of fluid underneath. And you can kind of appreciate that here. You can see that this is our abscess. We kind of have the head right around here. And you can imagine that if you pressed in this area, you would feel fluctuance and induration, which we talked about previously. This is a diagram of what it looks like, just a collection of pus here underneath the dermis and epidermis. These abscesses can be accompanied by symptoms like tachycardia and fever if they become systemic. And it's important to note that depending on the size of the abscess, you can choose to give antibiotics or lyse open the abscess, but this type of management is more of a step two question. It's more important that you're able to identify the bug that is associated with abscess, which is almost always going to be Staph aureus. That is the most high yield thing for you guys here. Lastly, let's talk about necrotizing fasciitis, which is easily the scariest infection we're going to talk about today. And let's let anatomy help us make sense of this. Previously, all of our infections had been in either the epidermis or the dermis. However, in neck fasc, we have infection of fascial planes. So I'm drawing two fascial planes here, right here. I'll label it for you guys. Now we're deep down in the fascia in terms of our infection. And we have a couple of bugs that can cause this. So we're looking at anaerobic bacteria like Clostridium and also Strep pyogenes. And what these do is they produce gases. And these gases like CO2 and methane, they can live right between the layers of the fascia. They're produced by these bacteria. And what happens on physical exam is when you physically press on these fascial planes, like pressing here on someone's arm or on their leg, it's going to make a popping sound, really similar to like when you pop bubble wrap when you get a package. And that sound is what we call crepitus. And it is extremely high yield in terms of the physical exam findings for necrotizing fasciitis. I cannot emphasize this enough. So other physical exam findings are going to be pain out of proportion on physical exam. We talked about crepitus, and you can also see some blistering or some purple erythematous red discoloration. However, I would not hang my hat on this part of the physical exam because it looks really similar to cellulitis or erysipelas, right? If we take a look here at this person's lesion on their leg, that looks really similar to what we saw earlier with cellulitis and erysipelas. So it's much better to hang your hat on findings like crepitus and pain out of proportion on physical exam. If you're new to pain out of proportion, it means that if you barely touch someone, they are like literally leaping off the bed in pain. Like
11, 12 out of 10 pain from the slightest touch. And that is what we mean by pain out of proportion on exam. In terms of a management here, it's going to be emergent surgery and antibiotics. You're going to have broad spectrum here, likely vancomycin, piperacillin, tazobactam, and surgical debridement in order to get source control from this fascial infection. Our differential, like we talked about, is going to be cellulitis and erysipelas. However, it's going to be differentiated by crepitus and pain out of proportion on exam. And that is it, guys, for our video on bacterial infectious conditions of the skin. I hope you enjoyed it. Remember, the best way to do well on step 1 is to stay busy. I'll catch you guys on the next video. Bye.
Hey guys, it's Jake here with Med School Bootcamp. Today we're going to be talking all about herpes simplex virus and varicella zoster virus infections of the skin. Go ahead and take a look at the outline right over here, and let's get busy. So first on the docket is going to be our herpes infections. Now there are 3 main causes of herpes infections. It's going to be our herpes simplex 1, herpes simplex 2, and varicella zoster. Those are the 3 viruses that cause herpes infections. Now, how do you recognize a herpes infection on step 1? It's actually pretty easy, okay? I want you guys to focus on some main points here. Let's start with our go-to in derm, which is visual diagnosis. So let's go straight to the source. These lesions are described as clear vesicles, which I circled here, on top of an erythematous base, which I'm circling here. An easy way to think about this, and an often way they're described, is called dewdrop on a rose petal, okay? So I'm going to highlight that here. Dewdrop on a rose petal. Here, what I circled, this is our rose petal, and this little circle, this clear vesicle, is the dewdrop, okay? Another great example of a dewdrop here, and we'll see we have a nice rose petal of erythema here. That's how you recognize a herpes lesion on step 1. It's actually really straightforward, and it's a big buzzword, so you know that you're in a herpes infection territory, okay? Some historical things that can help you recognize herpes patients is that they're going to usually be in some type of immunocompromised state, okay? So we're thinking like steroid use, HIV, sickness, any type of immunosuppressant, too much sun exposure, anything that's going to kind of derange the immune system is going to make people more likely to get herpes lesions. Stress is going to really cause these type of lesions too. Now, it's important to think of herpes infections as primary infections, which are going to be the first time you actually get a herpes infection, as well as a secondary infection, which is a reintroduction of the virus symptomatically. Our primary infections tend to be a lot more severe, so they tend to be like systemic and accompanied by fever, whereas our secondary infections tend to focus just more on the rash type symptoms, okay? So we talked about our 3 bugs that can cause herpes infections, so herpes simplex 1 and 2, as well as varicella zoster, okay? Let's talk about some important micro details. These are going to be enveloped double-stranded DNA viruses, and a great high-yield fact is that these are going to stain on a special smear called a Zank smear, okay? And this is a picture of that smear here, and an important finding is that you're going to see these dark intranuclear inclusions, okay? So I'm kind of circling 2 of those here. Anytime you hear intranuclear inclusion, and that's really important for it to be intranuclear, because we talk about inclusions a lot on step 1. So when you hear intranuclear eosinophilic taugery A, all of those are really hot words for herpes infections. Now, it's really important to differentiate from other type of inclusions, right? We have inclusions in asbestos, which are described as ferruginous bodies. We have inclusions in chlamydia, which are described as intracytoplasmic inclusions, okay? These are intranuclear inclusions, and that's really important. I want you guys to really focus on that because it's a key differentiating point, especially in a sexually active patient who could have chlamydia or herpes, and it's an important differentiation. So let's talk about a little bit how herpes infections are spread. Mostly we're thinking about skin inoculation with the exception of primary VZV infection, which can be due to respiratory droplets, which we'll talk about more in a little bit. And then an important part here is what happens after primary infection. These viruses actually go dormant in our neurons, okay? So they infect our skin. We have these skin lesions that we've described as dewdrop on a rose petal. After they've had their fun on our skin, they go deep down into our neurons and they rest. They take a little sleep. and they sleep there until they're ready to be reactivated and cause symptoms for us again. In general, the management of herpes infections is going to be antiviral medication, and we'll talk about the different antivirals that you can use depending on which infection you have. In terms of our differential diagnosis, it's going to be either the HSV infections or our varicella-zoster VZV infections. Okay? So that's the general overview. Now let's get a little bit into the weeds about each one. So let's talk about our varicella-zoster virus infections first, which I'm just going to refer to as VZV because it's much easier to say. So it comes in two forms. Our primary infection in childhood is called chickenpox. Our secondary infection is called herpes zoster or shingles. Here in the bottom area picture, we have a picture of chickenpox. Up here on the top, we have shingles. We're going to talk about differentiating the two and kind of the pathophys of how this primary and secondary infection happens. So let's start with chickenpox. It is a febrile illness of childhood. So you're going to have a child presenting with fever and this body-wide rash. This is a diffuse rash. Remember, we talked about the word diffuse meaning body-wide. So if we were to zoom in on each of these papules here, we would see it's a clear vesicular papule overlying an erythematous base, and it is body-wide, okay? These are primary infections, as we mentioned before, and it's important to note that chickenpox infections are self-resolving, so they're going to get better on their own without any medical intervention. An important part about chickenpox infections is how they're spread. So this is going to be due to respiratory droplets, okay? So chickenpox is the special one because it is spread by respiratory droplets, so you can be breathing the same air as someone infected with chickenpox, and you can also get chickenpox. Let's move on to talk about our secondary infection, which we call shingles, okay? So this is actually going to happen in the 6th to 4th decade of life, okay? So we're talking our 50-year-olds who are going to be getting shingles, or 60-year-olds who are going to get shingles, and it can happen in elderly as well. And this is a reactivation of VZV, okay? And what do I mean by reactivation? We talked about how these vesicular eruptions occur at the level of the skin, correct? In chickenpox and in shingles. So what happens after your chickenpox infection? The VZV virus actually goes very deep below the skin, and it enters the neuronal structures called dorsal root ganglia, okay? So I want you to imagine we have our spinal cord here in this gentleman, and then we have the dorsal root ganglia coming out and innervating his chest wall, correct? So we know that these are dermatomal distributions that these nerves track along. So for the past 30, 40 years, 50 years since this man had chickenpox, the virus was resting and staying dormant inside these dorsal root ganglia, okay? Now, let's say this man got a stressor, so he was on steroids, or he got too much sunlight, or he got an infection, or he's malnutrition, something like that, right? That is going to make the virus very nervous. The virus says, oh no, my host is not doing so great. I feel like I should get out of Dodge. I need to leave. I need to infect somebody else. So that stressor causes the virus to leave its comfortable home in its neuron, and it's going to move up to the skin and cause a vesicular eruption, okay? And this is what causes the classic shingles rash. Now, I want to mention something that's kind of important. A lot of times patients will describe a prodrome. So before they get any lesions, they kind of describe like this itchy, uncomfortable feeling on their skin. And then a couple days later, they have these vesicular eruptions. This prodrome is due to cytokine release as the virus is migrating out of the neurons and up to the surface of the skin, okay? Now, we talked about the dermatomal distribution, but I just want to re-highlight that here. So you'll see there's a very fine border of this eruption along a dermatome here. It does not cross the midline. So here, we do not have any virus that has moved over into this side. It is solely erupting out of this dermatomal distribution. That's an important finding in shingles, as opposed to primary infection, which we talked about being diffuse, not along any dermatomal distribution. So we talked about the dermatomal distribution arising from the dorsal root ganglion on the body, right? But there are some important pathologies of shingles that can happen on the face that are really high yield for the step 1 exam. So I'm going to draw my rudimentary face here. And I'm not the best artist, but here's the rudimentary face that I like to draw, okay? And here's my eyeball here. So let's talk about our first pathology first, which is going to be herpes zoster ophthalmicus. The key here is trigeminal nerve, specifically the V1 branch, which is our ophthalmic branch of the trigeminal nerve. So it's going to split off into 3 distributions off of V1. So V1 is going to have the frontal, the lacrimal, and the nasociliary, which is going to go out to the nose, okay? So what happens in shingles infection is we get reactivation within this distribution, and we can get pathology in the eye as well as rash on our nose and forehead. And this is going to be unilateral. So if this person was looking at us in the emergency room, my guy is really funny. He looks like he's not so happy that he has herpes infection. We would see lesions on his forehead, here on his nose, perhaps his cheek, and also redness in his eye, but it would all be on one side of the face. It would all be here on this side because it only infects one side of the trigeminal nerve at once. It would be very unlikely for you to get reactivation in 2 sides. So that's how you're going to recognize this herpes zoster ophthalmicus. And there's a special sign called Hutchinson's sign, which is when we get lesions here at the tip of the nose. So that's something to be on the lookout for. So next, let's talk about herpes zoster oticus, which is another important distribution of shingles virus of the face. So I'm going to go ahead and erase our V1 distribution, which was due to herpes zoster ophthalmicus. And now I'm going to draw my ear, and I'm also going to represent this little star is going to represent our geniculate ganglion, which is compromised of cranial nerve 7 and cranial nerve 8. So important here is what cranial nerve 7 and cranial nerve 8 do, right? So they're responsible for a lot of innervation, sensory and motor of the facial muscles, as well as things having to do with hearing and balance, okay? So I'm going to write down here, hearing, balance, and facial droop, okay? So if you have a patient who comes in with a real slumpy face like this and trouble with hearing or maybe trouble with balance, and you see some lesions over the face as well, you might be thinking that this person could have herpes zoster oticus. And that's because of this distribution here, as opposed to the previous distributions which we were talking about. And just so you guys know, this distribution has a special name called Ramsay-Hunt syndrome, okay? So when you have this collection of hearing, balance, facial droop, anything with cranial nerve 7 or 8, it is due to Ramsay-Hunt syndrome. So now let's talk about some of the management of our VZV infections. So we kind of talked about chickenpox, how we just do supportive care for these kidlets, okay? They have their febrile illness and their rash, it's going to resolve on its own without medication. As opposed to shingles, if you have an elderly person with shingles, it's really important that you treat them. A great option on test day is going to be famciclovir. And the reason why we treat these patients is really important because they can get what's called post-herpetic neuralgia. So let's say they went through their shingles infection, it was really painful, it was really gross, and they had a big red rash, and then everything resolves, okay? And then even though their rash is gone, they have this persistent electric pain along that distribution where they had their rash. This is called post-herpetic neuralgia, and it's due to derangement of the physiology of those nerves that just endured VZV just shredding them apart as they came to the surface of the skin. So that's something to be on the lookout for and why you should choose to treat every time someone has a shingles infection. Some other complications of our VZV infections are going to be Reye's syndrome. So if you have a kid with chickenpox, never, ever, ever give them aspirin, okay? And that's because giving them aspirin can precipitate a Reye's syndrome, which is a issue with the liver, which can actually cause death in kids. So never give aspirin to a kid with chickenpox. Another complication is going to be herpes zoster encephalitis. So this would be all of our classic dermatomal rash-like symptoms accompanied by now a change in mental status. And this is a very scary diagnosis. Additionally, if mom has VZV and is giving birth to her baby, you can get fetal transmission, okay? And this can cause issues with blindness, scarring, and shortened limbs in the fetus. So in terms of our differential diagnosis, we are in the land of dewdrop on a rose petal, so we always have to be entertaining VZV versus HSV. And we talked about some of the important aspects of VZV, and you guessed it, we're going to move to HSV next. Okay, so we talked about VZV. Let's move on to herpes simplex 1 and herpes simplex 2. So herpes simplex 1 is going to account for a much larger percent of infections than herpes simplex 2. Herpes simplex 1 is very, very common, and that's because most of us get infected with herpes simplex 1 when we're a child. And this is how it happens. Let's say mom is taking care of baby, she's drinking apple juice, having a great time taking care of her kid. She's like, hey baby, you want some of my apple juice? And the kid's like, yes, I want some. So they take a sip off the same cup, right? That is sharing of saliva, and that is how this disease is most commonly transmitted, okay? So not all of us are symptomatic. We're going to get symptomatic to herpes infections when we are relatively immunocompromised. So if we're really stressed out, get too much sunlight, are like sick or malnutrition, then we're going to get symptoms. The most common presenting symptom of herpes simplex 1 that we all know is a cold sore, okay? So I'm highlighting that here. This is our vesicular papule on top of our erythematous base. The official name for this is called herpes labialis because it's affecting the lips. And so this is caused by HSV1. Now, HSV1 is not just limited to the mouth, it's just the most known place for it to happen. But it can also happen in the eye, on the finger, esophagus, and also in the temporal lobe. And we're going to have a table and a visual diagnosis activity that's going to kind of go through each of these pathologies. Okay, so that's herpes simplex 1. Now, talking about herpes simplex 2, not as common as herpes simplex 1, and transmission is going to be through genital contact. So as opposed to saliva, this is going to be genital secretions being exchanged. So usually people who are sexually active, or sometimes, unfortunately, a child who is being sexually abused. Now, this is going to have lesions that look very similar. So we have our erythematous base here, and then we have vesicular papule on top of that. This is actually herpes here of the labia and the vagina, okay? So you're going to have anal or genital ulcers, and also on physical exam, you could have some inguinal lymphadenopathy, just like a lot of other STDs. So that's going to be an important differentiating factor. If you have inguinal lymphadenopathy, it could be multiple STDs, so you're going to really want to rely on your visual diagnosis to give a diagnosis of HSV2. Additionally, patients can have some dysuria associated with herpes simplex 2 infections, as well as some prodromal genital pain. So I kind of want to draw some pictures now and kind of describe this interesting constellation of symptoms, okay? So here I'm going to have a focal point here of what is going to be my sacral ganglia, okay? So here is my sacrum, and we know that the sacral ganglia kind of pop out here, and they innervate all the structures in our pelvic region, okay? So when herpes simplex 2 infections are happening, just like in VZV, we have a cytokine release as the virus is coming out. So we release cytokines as we're coming up to the skin, and that causes like an itchy burning sensation before patients actually feel lesions, okay? And this prodromal pain is going to be really, really common with the vaginal HSV2 infections, okay? Now, why do these patients get dysuria? This is not necessarily a UTI or an infection of the urethral tract. The reason is these sacral plexuses actually serve the structures of the bladder. So this is my bladder here, urethra coming out, and we have all the musculature in this area that is innervated by these sacral plexuses. So the herpes virus, it deranges this activity. So these patients might have frequency, urgency, difficulty completing their void, and that's another indicator that they may have an HSV2 infection. All right. So an important thing to note here is that the distribution of herpes simplex 2, like we talked about, is going to be sacral ganglia, whereas herpes simplex 1 is going to be trigeminal ganglia of the face, okay? So trigeminal. All right. And talking about our management of this disease process, when patients are symptomatic, they can get acyclovir or valacyclovir. Some complications of HSV are going to be HSV encephalitis, so be on the lookout for changes in mental status, as well as Bell's palsy if we get infection of cranial nerve 7, and fetal transmission as well. So if mom has active lesions, actually, even if she doesn't have active lesions, you can still transmit, but it's more likely if you have active lesions, then you can give HSV2 to the baby during delivery, okay? Our differential diagnosis here when we have herpetic lesions is always going to be VZV versus HSV, and we're going to use our table and visual diagnosis to help us make that distinction. Let's talk differentiating HSV1, HSV2, and VZV. So we know that anytime we have our dewdrop on our rose petal, we're in herpetic lesion territory, and it's our job to differentiate. So remember, HSV1, this is going to be our baby drinking apple juice from mom, right? This is going to be due to exchange of salivary contact, okay? HSV2, this is going to be sexual contact or during delivery, so thinking anogenital transmission. VZV, like we talked about chickenpox, you can get chickenpox just by being in the same room, breathing the same air as someone with chickenpox because it is airborne. You can also get it during delivery, okay? Let's talk about structures affected. So HSV1 affects the mouth, the eye, the finger, esophagus, brain. It can really be anywhere in the body, okay? Now, HSV2, we talked about being sexually transmitted, so it's largely going to be genitals and anus. All right, VZV, we talked about diffuse rash of the skin or a dermatomal rash of the skin, depending if it's chickenpox or shingles. It can also affect the eyes, the face, and the brain. We talked about those specific dermatomal distributions a couple slides back. So, dormant locations. HSV1 is going to be trigeminal ganglia, okay? It's going to be those nerves of the face that are going to really be the classic place for HSV1 to go dormant. HSV2, we talked about the urinary symptoms, the genital lesions. That's going to be sacral ganglia. VZV classically is dorsal root ganglia if we're going to get body dermatomal rash, or trigeminal ganglia if we're talking about rash on the face. Okay? So let's talk about some commonly quizzed facts associated with each virus. So starting with HSV1, we love to hear on step 1 about encephalitis, seizure, and aphasia, which are all neuro symptoms of HSV1. And that's because HSV1 really likes to infect the temporal lobe, okay? And we know that the temporal lobe is an area that is really prone to causing seizure activity, and it's also the location of a lot of our language structures, which is why it can cause aphasia in these patients. Some facts about HSV2, it is a anogenitally transmitted disease, so consistent condom use is the best means to prevent spread, okay? A common distractor they will try to give you is saying, oh, let's put the patient on long-standing valacyclovir oral therapy so they don't get lesions. That's never the answer. The answer is going to be consistent condom use. That's the answer they want you to pick. Additionally, they may make mention of children with genital lesions, and that's going to be heading you in the direction of sexual abuse, okay? In VZV, we talked about Reye's syndrome, never giving aspirin to a child with chickenpox. We talked about Ramsay-Hunt syndrome, which was the facial droop, as well as Hutchinson's sign on the nose. And then we talked about post-herpetic neuralgia, which was persistent pain after infection of a dermatomal distribution with shingles, and that the best way to prevent that is early valacyclovir therapy. So kind of the way I like to map these out on the body is, let's talk about VZV first, okay? So VZV, we know, is going to cause diffuse lesions, so lesions all over the body that are going to be dewdrop on a rose petal. And then later on in infection, that is going to present as shingles. It's going to be a specific dermatomal distribution like so. Maybe we have a dermatomal distribution on the face. It's going to be in a dermatome, okay? So that's VZV. Now, HSV1 is going to be non-dermatomal. So it's going to be in classic spots that we talk about, So like we technically tend to see it on the lips, temporal lobe, out on the finger, can even have it in the esophagus in people who are immunocompromised. Those are going to be the classic locations. HSV2 is all about that sacral area, okay? So genital lesions, sacral pathology, all right? This is how I think about these distributed on the body. So let's reinforce this all with visual diagnosis. So first things first, herpetic whitlow. This is HSV infection of the finger. So you see this is our lesion out here. This is a fresher lesion here. So this would be the primary lesion, how it would look, and then maybe after it's healing, it might look like this. You will get a step 1 question asking about a dentist. Dentists are likely to get herpetic whitlow because they have their hands in people's mouth all day, okay? So if they're operating on people's mouths who have HSV1, even if they wear gloves, they're just constantly exposed to that virus. So there's a chance that they're going to get it on their finger at some point when they're not wearing gloves or during movement of equipment. So always be on the lookout for dentists. This picture in 2 is going to be herpes stomatitis, okay? So this is going to be a herpetic lesion of like the palate. So it's going to be inside the mouth, all right? And then picture number 3 is herpes esophagitis. So an important finding in herpes esophagitis to differentiate from other forms of esophagitis. In herpes esophagitis, the lesions will be described as punched out lesions. So I'm going to like highlight them here. These are the punched out lesions described in herpes esophagitis. Whereas other esophagitises, such as CMV esophagitis, which is described as linear abrasions, and candidal esophagitis, which is described as like a chunky cottage cheese accumulation inside the esophagus, those are going to how you get differentiate from HSV1. So with HSV1, we're looking for punched out lesions. Here in picture 4, we just have another picture of our herpes labialis of the lip, which we talked about as being a common presenting feature. In image number 5, we have temporal lobe herpes encephalitis, okay? So you can see here that this temporal lobe is super, super bright on this image, and that's because it is infected with herpes encephalitis. We would expect this person to have seizure, perhaps some aphasia. In image number 6, we have herpes keratitis. So this is going to be a slit lamp exam with fluorescent dye stain, and you will see here this fluorescent dye highlights where we have our herpes infection along the surface level cornea. Now moving on to our visual diagnosis of VZV infections. So here we have a great example in number 1 of a chickenpox infection. Remember, this is a diffuse body rash for the primary infection. Then in image 3 here, we have a very dermatomal distribution. So this would be a recurrent infection, which we would call shingles, because now it is a secondary recurrent infection. It is along a dermatome. It is no longer diffuse. In image 2, we have herpes zoster ophthalmicus, which we described as infection arising from the V1 distribution. And if you look closely here, under the fluorescent dye from the slit lamp exam, you can see little patches of green here, which represent the herpes virus in the eye. This is very scary. It can cause blindness. So it's important that these patients get treatment with IV antiviral as soon as possible. In image 4 here, we have the classic dermatomal distribution of VZV on the face. So you can see it's only on one side of this lady's face. She has Hutchinson's sign here at the tip of her nose. She has a bunch of crusting all along here, and we know that she has infection of the eye because we can barely see her eye at all. This is a really bad infection of the trigeminal distribution on this woman's face. So just to bring it back to our summary slide, I just want to re-emphasize that anytime we see dewdrop on a rose petal, we're in herpes infection territory. It's our job to differentiate between herpes simplex 1, herpes simplex 2, or VZV. And the way we're going to do that is we're going to ask ourselves, is this a child? Is this an adult? Is this a primary infection? Is this a recurrent infection? Where is it located on the body? What type of activity or exposure have these people had? These are all ways that you can differentiate these different herpetic lesions on exam. Hey guys, it's Jake here with Med School Bootcamp. Thanks for tuning in to another video. Today we're going to be talking all about viral infections of the skin, so go ahead and take a look at the outline over here, and let's get busy. So let's get started by talking about molluscum contagiosum, which is going to be a disease of childhood, and it's going to present with small painless papules with central umbilication that are pearly or flesh-colored, and most importantly, not painful, okay? So let's look at these on gross exam. This is a great example here. You'll see that there's a central area of umbilication that kind of depresses into the greater lesion, which is raised on the skin. Also, an important thing about these lesions that you can kind of help notice is that they tend to do what I call a kissing lesion, okay? And kissing lesion has nothing to do with kissing itself, okay? Here comes my rudimentary drawing back into the ball game. So this is a person's arm, and here's their torso, okay? And let's say that a patient develops a lesion right here on their torso. And when they bring their arm down to their side, so let's say their arm adducts down here to their side and makes contact with this lesion over the course of a few days, all that rubbing, which we call kissing of the skin, is going to create a new lesion right here where those two surfaces interact. That is a really common finding of molluscum contagiosum. So these lesions will persist for about 6 to 9 months, and then they will just spontaneously go away without any intervention. Let's talk about a little bit of the microbiology associated with molluscum contagiosum. So it is an enveloped DNA pox virus, and it has some inclusion body histology on microscopy. So the inclusion bodies for molluscum contagiosum look like this. And they have these eosinophilic inclusion called Henderson-Patterson bodies, which look like this. And this is significantly different from the inclusion bodies we were looking at with our herpes infections, right? These look super different, which is why visual diagnosis on slides is really important. So you kind of want to burn this image into your mind. And this is inclusion bodies within the keratinocytes themselves. As far as the transmission goes, this is caused by skin-to-skin contact with another infected person. So like I kind of talked about the kissing lesion phenomenon, anytime you have rub up with someone else's skin or sharing towels, and a lot of kids are always hanging on each other and having a lot of skin-to-skin contact, this is how it is spread, okay? In terms of management, we talked about these being spontaneously resolving lesions, but there are some options for treatment which are generally not advised. So I want to tell you guys a little bit of a story. I actually had molluscum contagiosum when I was a kid, and I got it from skin-to-skin contact with another individual, my brother, okay? My mom was super scared. She doesn't have a medical background, so she saw these bumps popping up on her babies, and she was like, oh my gosh, we need to get them removed. So she took me to the doctor, and she said, can we please take these off? And the doctor said, you know, these are going to go away on their own. They're benign. If I try to freeze them off or cut them off, there's a risk that I could cause a scar by doing so. So the answer on test day is always just going to be, let it be. These are going to spontaneously resolve, okay? The caveat to that, when to be a little more worried, is if you have lesions that are larger than 1 centimeter or lesions that are throughout the entire body. So if you have lesions popping up that are really big or lesions that are just super diffuse across the entire body, that raises the suspicion for HIV. Additionally, if you have lesions on the genital area, that can raise suspicion for sexual abuse as well. So that's something to be important on your differential. So let's talk about some differential diagnosis for molluscum contagiosum. Chickenpox is going to look slightly similar. I think that the lesions are easy enough to tell apart because molluscum has these central umbilications, but also chickenpox will present with fever, whereas molluscum will be an afebrile illness. Warts from HPV tend to look a lot rougher in texture than the ones that we see here in molluscum contagiosum with central umbilication. And then when we're talking about milia, we normally see milia on the facial structures, whereas molluscum contagiosum tends to be on the trunk and the extremities. So that's another way to differentiate. Additionally, milia will not have central umbilication. It tends to be a finer white papule that's a little bit smaller than the lesions we see in molluscum. All right, next we're going to be talking about verrucae, which are commonly called warts. This is a common disease of children, young adults, as well as immunocompromised people. And these are going to occur on sites of skin-to-skin contact or places where people have some local trauma, okay? These warts are going to be caused by HPV. Now, there are a lot of different types of HPV, but they are all going to be double-stranded, circular, non-enveloped DNA viruses. Important facts about HPV: there are some high-risk subtypes that can cause cervical cancer that are important to know. They're not exactly derm-related, but they're highly tested on step 1. That's going to be forms 16, 18, 31, and 33. Now, these oncogenic forms, the reason why this happens is because the HPV virus makes something called E6. It is a protein, and it's going to inhibit p53, which we know is a protective mechanism against cellular division, which leads to oncogenic activities. There's also a protein called E7, which is going to inhibit RB, which is also an anti-cancer molecule. How do these look under microscopy? Well, warts are characterized by excessive epidermal hyperplasia, specifically in the stratum corneum. So you'll see there's really excessive hyperkeratosis here, which really leads to the warts having this really raised, rough, scratchy, rugged appearance on physical exam, which we will see in later slides. So the other thing is if you were to look really close under the microscope, you would see what we call koilocytes. And these are HPV-infected skin cells. And the way I like to remember koilocytes is, to me, they look like koi. So I'm going to draw a little koi here. And koi are beautiful fish that have big eyes and big mouths, right? So they have these big structures, okay? This is how I think of a koi. And to me, koilocytes look a lot like koi. They're kind of these fish-shaped cells, that is a tongue twister, with these big eyes representing their nucleus, okay? So that's how I remember koilocyte, and that's an infected cell by HPV. The management of warts is going to be supportive management unless the wart is causing a lot of issues, like if it's on the face or if it's becoming uncomfortable or interfering with ADLs. Then you can get cosmetic or functional removal. Usually this is cryotherapy or surgery. Some differential diagnoses for warts would be seborrheic dermatitis or skin tags. Way to differentiate these on exam is that seborrheic dermatitis is going to be usually excessively itchy, and it's not going to have as well-defined lesions as we expect in a wart, which we will see in a bit. And also under microscopy, we would expect to see characteristics of a fungal infection, and that's going to be like hyphae and branching rods and things like that. Additionally, skin tags tend to be a little bit more well-defined in terms of their structure. So what I mean by that is a wart, to me, looks like this, and it's really rough, kind of erupts from the skin like this. Whereas a skin tag, to me, tends to be like this. So it has a much narrower base and kind of hangs off the skin. And to me, skin tags are often a lot darker in color than warts. And also, they tend to be in the folds of the skin. So like in your neck, in your armpit, in your groin, that's where skin tags are going to occur. Whereas warts usually occur in areas of skin-to-skin contact. So like the fingertips, the nose, areas where you're touching a lot, that have a lot of interface, the soles of the feet. That is where you're going to expect to find warts. Let's move into some different types of warts that we have. So we'll start with common warts, which are called verruca vulgaris. So these are going to be white or flesh colored. Down here, I'm highlighting an example. It's really, really rough. You're going to find them most commonly on the hands, and they're going to be super rough, cauliflower-like texture. And you can appreciate that here in this picture. And then these are going to be due to HPV types 3 and 4. Next, we have flat warts, which are going to be most commonly found on the facial structures, so like the mouth and the forehead. And they tend to be like pink, light brown, light yellow. They're really flat and they just kind of lay right along the face. These are due to HPV types 3 and 10. Next, we have our plantar warts, which are going to be happening down here on the soles of the feet. These occur in areas of high tension slash friction. So think like the balls of your feet, the areas that get a lot of pressure. They're going to be accompanied by a lot of hyperkeratosis and callus formation. And these are due to HPV type 1. Next, we're going to have anogenital warts, which are known as condylomata acuminata, and these are sexually transmitted type of warts, and they are due to HPV types 6 and 11. All right, guys, let's get busy talking about hairy leukoplakia, which is going to be a dermatological condition most often found on the tongue. Now, there are a number of dermatological conditions that appear on the tongue. And so when it comes to framing hairy leukoplakia, I want you guys to be framing it against a differential diagnosis. So we're going to talk about the pathophysiology of hairy leukoplakia and why it happens, but I want you to have this active differential in your mind as we make our way through this slide. So when it comes to hairy leukoplakia, our tongue is going to be the most common area, and it's specifically going to be the lateral areas of the tongue. So if we look here, I'm going to outline this lesion, and you'll see it's on the lateral surface of this person's tongue. And this is where hairy leukoplakia pops up the most. And this is important to differentiate from something like thrush, which is going to occur on the very top surface of the tongue right here, and it's going to be easily scrapable. So if I was to try and scrape this hairy leukoplakia lesion, it is not going to scrape off. It is like a permanent fixed lesion, whereas thrush is like having a thick white layer of cottage cheese on top of your tongue that can easily be scraped off. So if I was to draw an imaginary tongue, like here's the top of the tongue, here would be the uvula. Our thrush infections are going to occur up here on the top of the tongue. It's going to be like a cottage cheese-like discharge. And then our hairy leukoplakia is going to be on the lateral sides of the tongue here, and it is not going to be scraped off. And that is going to be a key differentiating factor if you have a patient presenting with an unknown white lesion on their tongue. So let's just go ahead and review some of the facts here. It's irregular and white, and it's going to be painless. This is not going to be a painful lesion. This is just going to be something that patients notice perhaps when they're brushing their teeth or flossing and it comes to their attention. And like I said, important high yield fact here is that it cannot be scraped off. When it comes to the microbiology and the etiology of why this happens, it's going to be due to EBV or HPV strains. And this is primarily going to be for our viral mediated hairy leukoplakia, but there are other ways to get hairy leukoplakia besides viruses. So let's kind of talk about some of those next. So when it comes to other pathophysiology, it's basically going to be squamous hyperplasia of the oral mucosa. This can be due to insults from viruses. So if you guys remember to something that we're all familiar with, which is cervical cancer due to HPV, that's going to be due to changes to dysplasia in the cervical region because virus infection there aggravates those cells and the body responds with dysplastic changes. Now, the similar thing is kind of happening here with hairy leukoplakia. A virus like CMV or EBV is aggravating these cells, and we are getting a squamous hyperplasia here, and that is what this white plaque is. It can also be mediated by infectious or toxic exposures. So things that I like to think about that can cause hairy leukoplakia are things that can cause irritation to the mouth. So I'm thinking about things like alcohol use, things like smoking, things like chewing tobacco. These are all going to be caustic insults to the mucosa. Additionally, people who wear dentures for a long time and maybe don't do the best job of cleaning them are also at risk because those dentures can be really aggravating and lead to that squamous hyperplasia. So now let's get down to our differential, which was like the important thing that I really wanted to point out. So we talked about thrush and how thrush is important because thrush is scrapable, right? And thrush is also going to respond to a fungal therapy. So we know that thrush is due to a fungus, whereas hairy leukoplakia will be due to viruses or caustic insult. Next, let's talk about lichen planus. And lichen planus is going to be described as a lacy reticular deposition, and it's usually found in the lateral areas of the mouth. So right here and right here. So in our drawing here, it would be on these lateral surfaces of the mouth where we would expect to find this pathology. And this pathology is going to look much different. So previously here in hairy leukoplakia, we have this big plaque, whereas in lichen planus, we're going to expect these reticular, really lacy like fibers that kind of look like so, and they're spaced out and they're really lacy, almost like lace on a dress. This is what lichen planus is going to look like. And it's also not going to be as opaque and as white as hairy leukoplakia. It's going to be more like translucent and almost like a clear silvery deposition on the lateral sides of the mouth. And this is usually going to be associated with hepatitis C. So they like to mention hep C in these patients, whereas hep C is not going to be causing our hairy leukoplakia. The last thing on our differential is going to be oral squamous cell carcinoma. And this is difficult to differentiate from hairy leukoplakia, and thus this changes our management of hairy leukoplakia. Hairy leukoplakia itself is benign. However, it is difficult to differentiate from squamous cell carcinoma, and it can transform into squamous cell carcinoma. So it's important that we get biopsy to assess for neoplastic growth. And this is going to be especially true in anyone who's doing ETOH, smoking, chewing tobacco, dentures, anything that can lead to insults to their oral cavity is going to lead to squamous cell carcinoma. So we have to screen for it. So in terms of differential, I would say the highest yield fact here is that hairy leukoplakia is not scrapable. That's going to be your key dead giveaway. Also, the fact that it's going to be found on the lateral aspect of the tongue is going to really help you on testing. All right, guys, let's get busy with our content on Candida. We're going to start by talking about mucocutaneous candidiasis infections, and then we're going to go ahead and talk about candidal intertrigo. So go ahead and stay tuned and let's get busy. All right, guys, let's get busy talking about mucocutaneous candidiasis. And let's start off by talking about our presentation here. So the highest yield presenting fact is going to be a scrapable white plaque. And I want you guys to direct your attention down here to our tongue here in the bottom right corner that I'm outlining here in blue. And this is a plaque that is classically going to show up as mucocutaneous candidiasis. And if you were to take a fingernail or a tongue depressor and you were to scrape along this tongue, this white plaque down here would easily scrape off onto whatever object you were scraping with. And that's going to be a really high yield sticking point for candidiasis on test day. Let's talk a little bit about who gets our mucocutaneous candidiasis infections, because this is going to be just as important in question vignettes. So in terms of risk factors, the first one let's talk about is going to be antibiotic therapy. And antibiotic therapy is going to be a big risk factor. Normally in our mucous membranes, we have flora that are living in harmony together. And these are going to include things like various bacteria and various fungi, one of them being Candida. And in my picture here in orange, I'm going to annotate that these are Candida bugs. So Candida is going to be a normal flora of our mouth. Additionally, we have normal flora of bacteria, which I'm going to highlight here in green in my picture. And the thing is, when we give a patient antibiotics, what it can do is it can knock out the normal flora, especially the bacterial flora, because antibiotics target bacteria, but they're not really going to do much to fungi. So all of our bacteria are going to be killed off from our antibiotics, and then it's going to give room for our candida to really overgrow. So you're going to see I'm going to add like many orange dots. And these orange dots are going to come to represent that scrapable white plaque, which is candidal overgrowth. So that is going to be the pathophysiology of how antibiotic therapy leads to overgrowth of candida. But there are some other risk factors as well, one of them being diabetes. We know that patients with diabetes have very poor glucose control. And with poor glucose control, you're going to get a breeding ground for candida because candida loves sugar. It's a fuel source for candida. So if you have mucous membranes with higher than normal glucose content, you are going to have a breeding ground for overgrowth of candida. And this is why uncontrolled diabetes is a big risk factor for candidal infections. Next, let's talk about steroids in immunocompromised states. So we know that steroids are going to knock down our immune system. And our immune system is responsible for keeping normal flora at bay, one of those being candida. So if our immune system is knocked down, whether it's from steroids or some other immunocompromised state, this is going to allow candida to grow out of control up to the levels where we're going to see the scrapable white plaque. I want to further emphasize that when it comes to immunocompromised states, the area that really tends to be tested on test day is going to be the esophagus. And there are two high yield sticking points here for esophageal candidiasis because esophageal candidiasis is really not normal. It's going to be only something we get in immunocompromised states. So, one specific immunocompromised state is going to be our corticosteroid inhalers. So, if our asthmatic patients or anyone else using a corticosteroid inhaler is breathing in corticosteroids locally to the area of their pharynx, their lungs, their esophagus, they can get localized immunosuppression in that area. And this is going to allow candida to grow out of control in the esophagus. Additionally, those with CD4 counts less than 100 are very likely to develop candidal esophagitis. And this is going to be an important sticking point in terms of our HIV/AIDS patient questions, especially the CD4 count. They love to ask the CD4 count at which esophageal candidiasis will occur, and that's going to be when the CD4 count drops below 100. Let's move on to talk about some of the microbiology of our mucocutaneous candidiasis infections. So we've been talking about the fact that our bug is going to be Candida albicans, and this is going to stain very nicely on a KOH prep. And KOH prep are useful in identifying fungi. That's what we use them for. And since Candida is a fungus, it will show up on KOH prep. So when it comes to looking at this KOH prep, what exactly are we looking for? Well, we're actually looking for two different things. We're going to be looking for pseudohyphae and budding yeast, as well as germ tubes. And this is going to vary on the temperature at which we find Candida. So from 20 to 25 degrees Celsius, we are going to be looking for pseudohyphae and budding yeast. Whereas at 37 degrees Celsius, we're going to be looking at germ tubes. And an important hot word for this phenomenon is called being a dimorphic fungus. So dimorphic fungi exist in two different forms depending on what temperature they are. So we're going to have form 1 at temperature 1 and form 2 at temperature 2. And this is going to be apparent on this slide. So on this slide, we actually got really lucky to see Candida in both of its forms. So in our pseudohyphae and budding yeast, I'm circling it here, and you can see that this looks much different from our germ tube formation, which I'm going to circle out here in the periphery. And this is because this fungus was probably at an area where we had some variable temperature. And when we plated it, we happened to get this sample in two different forms. And so this is what is characteristic of a dimorphic fungus, meaning it exists in two different forms at two different temperatures. Let's move on now to talk about some of the higher yield immunology and pathophysiology associated with Candida for test day. So, two important things here. I want to talk about T cells and I also want to talk about neutrophils because these are both going to be related to our Candida infections. So, it is our T cells that are responsible for defending against Candida in the cutaneous regions of our body. So we're thinking skin, mucocutaneous areas like the mouth, esophagus, and vagina. These are all going to be patrolled and defended against Candida overgrowth by T cells, whereas neutrophils are responsible for bloodstream infections by Candida. So Candida bloodstream infections can occur when patients have chronic lines, especially those who are receiving nutrition via IV. And the defense from Candida in this setting is going to be from neutrophils, whereas everything cutaneous is going to be T cells. So it's important to be able to differentiate those two on test day, especially on third order questions involving immunology. So I just want to re-highlight here that T cells are going to be responsible for infections of our mucous membranes. Specifically, it's usually going to be the oral mucous membranes or the vaginal mucous membranes on test day, but this could also apply to skin infections as well. In terms of our management of Candida, it's going to be all about antifungal agents, and we have a variety at our disposal, and these are going to vary a little bit depending on what area of the body is being affected by Candida. So for oral candidiasis that is simple and non-complicated, we can give an oral nystatin rinse. So this is a simple swish and gargle. The patient spit it out, and this should take care of any candidiasis on the tongue or in the mouth. When it comes to vaginal candidiasis, we are going to use a topical azole, and this is just applied topically in the vaginal area, and it should take care of this candidal infection. Importantly, when it comes to esophageal candidiasis, IV fluconazole is going to be a really high yield sticking point on exam day. They love to ask that when it's esophageal candidiasis, you must give fluconazole in the form of an IV medication. And this is because it has better penetration and it's much easier to reach the esophagus, which is normally a hard area for us to reach with topical treatments. Lastly, if we have a refractory infection, we can use a systemic azole. So we can use oral therapy here in order to get a much stronger punch. But we always like to go conservatively and start with a topical treatment, but we can always step up to systemic therapy as well if we need to. In terms of forming a differential for Candida, there are a few things to be on the lookout for that might be confusing on test day. I want to start by talking about hairy leukoplakia. And hairy leukoplakia is going to be a non-scrapable plaque that is usually found on the lateral portions of our tongue. So whereas mucocutaneous candidiasis is found like right on top of the tongue, like we talked about earlier, our hairy leukoplakia is going to be on the lateral aspects. And so that's something that is going to really help you, as well as the fact that hairy leukoplakia will not be able to be scraped off where candida will be. Next, I want to talk about HSV and CMV infections of the esophagus because this is a pretty high yield physical exam finding that we like to talk about. So in HSV and CMV esophagitis, there's going to be two specific lesions that are going to be talked about. When it comes to HSV, we're going to have HSV described as punched out lesions. So punched out lesions in the esophagus are going to kind of look like these discrete circles that are punched out along the esophagus. Whereas in CMV esophagitis, we are going to have it described as linear lesions. So they're going to look like vertical lines along the esophagus. And these lesions, as described as punched out and linear, are going to be high yield when it comes to describing HSV or CMV esophagitis. However, candidal esophagitis will be described as cottage cheese like buildup. And this is going to be very different from those other hot buzzword descriptions. Also, we can have pill induced esophagitis, and we are usually going to have some sort of history of excessive pill taking or new medications that have been started, especially drugs like bisphosphonates, which have to be taken sitting upright with a full glass of water. I also want to talk about infectious vaginitis. So, in infectious vaginitis, which I'm going to highlight down here, is we have a cottage cheese like buildup inside the vagina. However, there are other causes of vaginitis, usually sexually transmitted. So, we're going to have things like bacterial vaginosis, which tends to be described as a gray discharge, a gray, watery discharge with a characteristic fishy smell. Whereas we can also have trichomoniasis, which is going to be described as a frothy green discharge with motile organisms on wet mount. However, in candidal vaginitis, it's going to be a thick, white cottage cheese like discharge. And that's going to be your dead giveaway that you're dealing with candidal vaginitis. And for that, we can give a topical azole. Lastly, I want to touch on chronic mucocutaneous candidiasis. So, if you have a person who comes to you, usually going to be a younger or middle aged patient with chronic recurring mucocutaneous candidiasis infections who doesn't have any of the risk factors that we talked about above here, we may be on the lookout for an immunocompromised state that is inborn. And what happens in these people is they actually have a defect in their T cells, specifically air genes of the T cells. And these T cells are not able to defend properly against candidal infections. And so these people get chronic candidiasis infections despite no risk factors that we can identify. And so if you suspect this person, it's usually going to be someone presenting at a younger age because they really don't have any other comorbidities. And you're going to be able to suss out this diagnosis. And it's going to be related usually to a third order immunological question relating to T cells and air genes. So to wrap up, I would say the most important things to know about mucocutaneous candidiasis is that we are going to have a scrapable white plaque. It is a fungus, so it's going to be identifiable on KOH prep, and it has that special dimorphic qualities in that it exists differently at different temperatures. And finally, when it comes to treatment, we're going to have a variety of antifungals at our disposal. And it's important to know that based on the location, we're going to use different types of antifungal therapy. Let's move on to talk about candidal intertrigo, which is going to be another form of candidal infection, but this is primarily going to be affecting the epidermis, whereas in mucocutaneous candidiasis, we were talking about all of our mucous membranes. So this is the same bug, it's just going to be infecting a different part of the body. So in terms of pathophysiology here, the bug is still candida. However, we are now infecting the epidermis instead of the mucous membranes. Now, let's talk a little bit about who this happens to and why it happens. So there's two really important words that I want you to associate with candida infections. And the first word is going to be hot. Hot conditions are really important for the breeding of Candida on the skin. And the second word, which no one likes to say, is moist. And I know nobody likes that word, but hot and moist conditions are what are going to lead to a breeding ground for Candida. So if you guys are just thinking about heat and moisture, that will lead you on the right track to Candida infections of the epidermis. So some things that I like to think of are boots that have very little ventilation, diapers, especially diapers that are wet and have been having a lot of urine and heat. And this applies to both babies and people who may be bedbound. Additionally, people with heavy skin folds. So, obese patients with a lot of overlapping skin are going to get Candida infections where they don't have a lot of ventilation into those skin areas. Additionally, people who are in hot and moist environments like locker rooms or jacuzzis or anywhere that is high heat and high moisture are going to be at risk for Candida infections. In terms of the lesions themselves, they tend to be erythematous, raised, pruritic, and beefy red. So if we take a look down here at our main lesion, we'll see that this is like the main beefy erythematous part of the lesion right here. And this is what a candidal intertrigo infection is going to look like. But I want to point out something that's really important in terms of high yield differentiating from other infectious rashes. You will notice that there are satellite lesions, and it's these little circular pod-like guys who are existing off the main part of the rash. And this is a super, super high yield sticking point for candidal infections because other infectious disease processes will not have these satellite lesions, whereas candidal infections will. So just remember, it's going to be beefy red erythematous, it's going to be pruritic, and we're going to have those satellite lesions. So I want to highlight the satellite lesions in extra dark red because it's extra important. And we talked about how it's going to be more common in our obese patients or patients with overlapping skin folds. And then we also have it being more common in diabetic and immunocompromised patients. And this is very similar to the mucocutaneous candidiasis, where our patients with high blood sugar levels are going to have a breeding ground for Candida, and those with compromised immune systems will be less likely to be able to fight off Candida infections, allowing it to grow easier on the skin. Let's do a quick recap of the microbiology here. The bug is the same. It's going to be Candida albicans, just like in mucocutaneous. We're going to be able to see this on KOH prep. And remember, it's important to note that Candida is a dimorphic fungus and that it lives in two forms, both the pseudohyphae and budding yeast form, as well as the germ tube form, depending on what temperature it lives at. If we take a look at our picture here, this is going to be the germ tube form that I'm outlining here. We see this nice long germ tubes, two great examples here on this slide. And remember, this is going to be a KOH prep that shows fungi. In terms of our management, it's pretty simple. We're just going to use topical nystatin wherever the Candida is growing. And this is great because we can like lift up skin folds and apply this medication locally, and it should take care of the infection. However, if people have a refractory infection to topical treatments, we can also provide a systemic azole, and that should take care of the infection. I want to wrap up by talking a little bit about some differentials for Candida. And so tinea and erythrasma are going to be two differentials that are both going to have well-defined borders. And what I mean by well-defined borders is that there are going to be no satellite lesions. So previously we were talking about the satellite lesions that are specific to Candida, whereas the borders of tinea and erythrasma are going to be well-defined. So we're going to have this solid plaque that's also going to be erythematous, raised, and pruritic. However, there will be no satellite lesions on the outside here like we would expect to see in Candida. Also, under a Woods lamp, erythrasma is going to stain a coral red color, which is a high yield buzzword specific to erythrasma that we would not expect to see in Candida. Lastly, let's talk about a non-infectious differential here. This is going to be atopic dermatitis, also known as eczema. So eczema is going to be really common in our children. And usually these children are going to lack any history of a hot or moist environment or a history of being immunocompromised or having diabetes. So we can expect maybe a Candida infection in the diaper area of a child. But really, other than that, we wouldn't expect an infection of Candida in a young child. And so it would be more likely that we're dealing with something like atopic dermatitis in our pediatric population. Additionally, atopic dermatitis is going to be treated with steroids, whereas Candida is going to be treated with antifungals. And so if it's a treatment treatment, pharmacologic based question. That may be another way that you may be able to differentiate the two based on response to treatment. Also, the fact that atopic dermatitis tends to be a chronic condition, and our candidal intertrigo infections are going to be much more acute after exposure to a hot and moist environment where Candida may be living. So that's how you want to differentiate atopic dermatitis from Candida on test day. Hey guys, it's Jake here with Med School Bootcamp. Thanks for tuning in to another video. Today we're going to be talking all about fungal infections of the skin, so go ahead and take a look at the outline over here. One thing I want to mention, our first 4 cases of the day are all going to be about dermatophyte infections, and the last 3 are going to be fungal infections of other types. So without further ado, let's get busy. Let's start off by talking about tinea corporis, which is going to be a fungal infection of the epidermis that affects many different parts of the skin. So let's get started by taking a look at how this lesion looks like. So you'll see that these are beefy, red, circular, raised plaques. And that is going to classically be in areas where we have skin overlap or a lot of heat. So typically underneath garments that have like a lot of sweat or are really warm. So it's typical to find these in areas like underneath the breast or like along the axilla, anywhere like that. One thing I want you guys to pay attention to is that these lesions have an outer area of thick erythema and kind of a central clearing. And this is because when the fungus infects, it will kind of drop in right where I'm highlighting with my pencil, and it shoots out spores like spokes on a bicycle wheel. And then those spores propagate out here at the periphery again, and that's what makes that darker ring of erythema. Really cool. Also, these do not have satellite lesions like Candida infections, so that's a great way to differentiate from the fungi infections of Candida. Now, I want you guys to just refocus. These are erythematous, raised, peritic, and with central clearing, okay? Also, they're going to have the sharp borders like we mentioned before, no satellite lesions here. Let's talk a little bit about the microbiology of this. So this is a dermatophyte infection. The 2 dermatophytes in question are going to be trichophyton and microsporum. So I'm going to highlight those 2 for you guys. Trichophyton, microsporum. These are going to be identifiable on KOH prep, which is how we see fungi underneath the microscope. Highlight that for you guys here. And let's take a closer look at the microscopy. You'll see that these have microtubules with segmented hyphae. So that's what I'm kind of highlighting here, these like segmented hyphae that branch off of the tubules themselves. Pretty cool microscopy here. And then I want to talk a little bit about the risk factors that you're going to see in a patient who has this disease process. So I'm going to write down 2 important buzzwords for you guys, and that's going to be hot, and the next word, I know everyone hates this word, but moist. So hot and moist environments are where these dermatophyte infections are going to thrive. So gyms, pools, saunas, overlapping skin, diapers, all of these environments are going to be ripe cause for these infections. So I'm going to highlight in orange, history of high heat and moist exposure, because orange to me is like a really warm color. So in terms of the treatment of this condition, it's pretty easy. You're just going to throw an antifungal wherever you see the rash. So our go-to is going to be a topical azole or topical terbinafine, but if that doesn't work, we can always escalate to oral therapy as well. But most importantly is going to be hygiene practices. So whatever environment or whatever area this fungus was thriving in, we need to take care of that. So that's having better diaper changing, having less moist environment like underneath the breast, wearing clothing that is going to breathe. Anything to make us not be hot and moist is what is going to cure us from this disease process. So that is super, super important because they will often mention that on test questions as the first choice. So in terms of our differential diagnosis for this disease process, we talked about candidiasis as having satellite lesions, and that's a key differentiating factor here for this differential. Also, Candida is sometimes mentioned as a dimorphic fungus, whereas dermatophytes are not. Additionally, pityriasis rosea is going to have a really itchy, erythematous, plaquey type rash, but this is usually associated with some type of viral infection, and it usually has a prodrome and a herald patch, so that's a great way to differentiate it. Additionally, it classically is described as having a Christmas tree distribution, whereas these dermatophyte infections do not have a Christmas tree distribution. Our last thing on the differential is going to be erythema multiforme, which classically is described as having a central clearing. But with erythema multiforme, I'm highlighting it in gray because these tend to be described as a dusky gray clearing instead of a clearing that is like what we describe with the bicycle spokes here in the dermatophyte infection.
So next, we're going to talk about tinea capitis, which is going to be a dermatophyte infection specifically of the scalp, and it's going to present as a very itchy scalp with associated hair loss and even cervical lymphadenopathy because the infection actually causes an inflammatory reaction within the cervical distribution. So I'm just going to highlight itchy scalp, hair loss, cervical lymphadenopathy. Now, let's take a look at what this looks like on physical exam. So classically, this is going to be a patch of hair loss, and it's going to be described as broken strands of hair, and that's because patients are itching and causing physical trauma to the hair. And these are described as looking like black dots. So I'm going to highlight this for you guys. Broken hair strands, black dots, and this is classically going to present in African American boys. So in terms of the microbiology here, we're still in dermatophyte land. So we're looking at trichophyton and microsporums, specifically microsporums on the outer shaft and trichophyton is on the inner shaft, but that's pretty low yield detail in my opinion. More importantly is that this is going to stain positive on a KOH prep, which we use for fungi. And under Wood's lamp exam, it's going to actually have a bluish green fluorescence. So I'm going to highlight here in blue. I'm going to go over it again with green so you guys know that it's like a blue-green fluorescence. In terms of our management of this disease process, the most important thing is going to be hygiene practices. So if you have a dirty hat, a dirty wig, a dirty anything, a dirty comb, you got to switch that thing out because if you're sharing that with brother or sister or friend, you're going to spread the disease. And even if you cure it, you're going to get it again. That is the number one thing. Hygiene practices. Always pick that number one. But if you have the infection in your scalp, we need to treat it. So antifungal shampoo or oral griseofulvin and terbinafine are going to be our options for treating this. Now, in terms of the differential diagnosis, we have trichotillomania, alopecia areata, and seborrheic dermatitis. So trichotillomania is usually going to be associated with some type of site condition. And when we're talking about alopecia areata, this is an autoimmune process, so be on the hunt for other autoimmune conditions. And also, this hair loss is described as coin-shaped, patchy areas of hair loss. And finally, on our differential, we have seborrheic dermatitis, which is also going to be itchy. However, this is going to present more like dandruff with a lot of flaky scalp. And it also may have associated infection area in the T-zone of the face. So that's going to be your differential for tinea capitis. So next, let's talk about tinea pedis, which is going to be dermatophyte infection of the feet, hence pedis. You can see that we're playing with a lot of like Latin and Greek prefixes here. Basically take tinea and add on a Greek or Latin word for some body part, and you got yourself a dermatophyte infection. So let's look at this one. It's going to present with fissuring, which is a fancy word for cracks. You can see all this cracking along this person's foot here, also with some erythema along the medial aspect here, and you can see that there is diffuse scaling all over this person's foot. This is classic infection of tinea pedis. Now, if this was to all happen on the hand, falling in line with our Greek-Latin fun, we would have tinea manum if all this happened on the hand. This is less common, but it can happen. So, you guessed it, guys. We're on a theme here, dermatophytes. So trichophyton, microsporum, and epidermophyton are going to be what cause this disease process. And it is identifiable on KOH prep. And the microscopy is going to show segmented hyphae, just like we talked about before. So the pathophys is pretty similar to before. It's just a superficial fungal skin infection, this time on the foot epidermis. It's caused by hot and moist environments, just like our other ones. And fun fact, I have had this. I used to swim a lot and play water polo. I was always in hot and moist showers and locker rooms, and I got this disease process. I was treated with topical azoles and topical terbinafine. However, I did not have good hygiene in high school, and this came back because I was always on the pool deck. So, number one thing to mention, hygiene practices. That's always going to be your number one choice here. So, don't miss that on test day. Now, if you have a refractory condition of this, you can always step up to oral therapy. However, that is not likely to be the first answer choice on test day. In terms of our differential diagnosis, our onychomycoses are going to be fungal infections of the nail. So if it's tinea pedis, it is the foot, and if it's onychomycoses, it is the nail. So this brings us to onychomycoses, which is going to be our next dermatophyte infection. This time it's specifically going to be attacking the nail. So we're going to see thick yellow white nails with flaking, and the nail can even separate from the nail bed. Ouch, that hurts just thinking about it. Here is a classic picture of what it looks like. You can appreciate that gray, yellow, flaky, thick nail. And our bugs are going to be dermatophytes. It's going to be trichophyton, microsporum, epidermophyton, just like before. And it's going to be superficial skin
skin infection of the nail itself. So just like before, heat and moisture exposure are going to be key in history, and hygiene practices are going to be essential. On top of topical antifungals like azoles and terbinafine, we can always use an oral agent if it is refractory or patients want it to be done faster. Now, in terms of our differential diagnosis, we just talked about tinea pedis and how it is only a matter of nomenclature. The nail is onychomycosis, the skin is tinea pedis when we're talking about down here in the feet area. I want to take a quick moment to just say, everyone, let's pause and note that we are leaving dermatophyte land. So we were previously talking a lot about dermatophyte infections and all their similarities and how they just kind of differed in location, but we are leaving dermatophyte land and now we are entering tinea versicolor, which sounds similar because it has tinea in its name, but it's from a completely different bug. And I just want to highlight the bug for you guys so you know we're in different territory. So the bug is going to be Malassezia furfur. Okay, now let's talk about how this presents. This is going to present as macules that can either be hyperpigmented, meaning darker, or hypopigmented, meaning lighter than surrounding skin, that can coalesce into larger patches. So you can see here we have little tiny macules that coalesce into large patches. These can be slightly pruritic, but it's truly not characteristic of the disease, so I wouldn't hang your hat on that part of the diagnosis. So let's just go over this. Round macules, well-defined borders, coalescing into patches. You can find this in areas of heat and moisture, so you're going to find it on face, neck, and abdomen. The discoloration can be hyperpigmented, which is darker, or hypopigmented, which is lighter than surrounding skin. And depending on your skin color, this may present as white, yellow, tan, or brown. And like we said, do not hang your hat on pruritus because it's not really characteristic of this disease process. In terms of the microbiology, it is a fungus, so we will be able to stay on KOH prep. But here's your winning word, guys: spaghetti and meatballs. That is like A plus buzzword for this disease process. I'm going to highlight in red because spaghetti and meatballs is red. You're going to see these multi-branching hyphae with budding cells. Here's an example of electron microscopy, and here's an example of the light microscopy. But just listen for that buzzword of spaghetti and meatballs because it is super high yield. So let's talk about some pathophys. This is going to be an infection of the epidermis. And key here, the fungus loves to just like feast on lipids. And these lipid feasting causes some production of acid. And this acid is going to affect tyrosinase. It's going to basically knock out tyrosinase, which is responsible for helping us make pigment. So if that's not working, then we're going to have a decrease in pigmentation. And that's what causes this altered skin appearance. So you'll remember that these enzymes are important in other pathologies like albinism, so this may help connect some of the pathophysiology for you guys. In terms of management, we're going to use topical shampoos, the most high yield of which will be selenium sulfide. In terms of our differential diagnosis, vitiligo is going to be the top one, but remember that vitiligo loves to attack the extremities, so think like fingertips, toes, tips of the nose, ears, whereas tinea versicolor is going to be more of a central disease pattern with it like appearing on the chest and the trunk and the axilla, areas where it is warm. So that's how you're going to differentiate here between vitiligo and tinea versicolor. Next, let's talk about sporotrichosis, which is commonly known as rose gardener's disease. So I'm going to highlight everything in red so it reminds you of roses. And this is going to present as red, painful nodules and ulcers with pus. Also, it's going to be associated with something called ascending lymphangitis, which is pretty high yield here, guys. So let's talk some pathophys. Essentially what happens is you have a history of like a gardener or a landscaper, someone who works with like wood clippings or roses is going to be in the history, and they're going to prick their finger on a rose bush or a piece of bark. And so let's say that prick happens down here. This is where the fungus infects, and this fungus is called Sporotrichschenckii. And what it does is it travels up lymphatic tracts all the way up the arm. And as it does so, it leaves these like eruptive ulcers along the way. So this is a classic and honestly amazingly cool physical diagnosis finding. So I really want you guys to like burn this picture into your mind because you'll see it on test day. So we talked about why this is called rose gardener's disease. And importantly, even though this looks really scary, the systemic symptoms are not going to be present. Unlike like an abscess or a cellulitis, these patients are unlikely to get systemic symptoms. So systemic symptoms very rare here. We talked about the bug being Sporotrichschenckii and how it lives in vegetation, especially roses and bark. It is a dimorphic fungus, which remember we talked about, meaning it can exist in 2 different temperatures. And here's a super high yield moment coming your way. I'm going to highlight in brown. This is a cigar-shaped fungus on microscopy. So let's highlight what that that looks like on the microscopy itself. You'll see here what I'm circling is like kind of like a cigar shape, and that is classically how the fungus is described. So be on the lookout for that cigar for that winning point. In terms of the pathophys, we talked about how this fungus loves to inoculate a site and go up lymphatic tracts, causing this amazingly cool physical diagnosis. And if we talk a little bit about management, the first line treatment is going to be itraconazole, and other options are going to be potassium iodide, as well as amphotericin B if we have a really scary disseminated infection. In terms of differential diagnosis, we talked about abscess and how it can usually sometimes present with systemic symptoms, and also abscesses aren't going to have this like beautiful like linear lymphatic tract, so that's a really great way to differentiate it. We also have lymphangitis, which is a pretty non-specific disease process, and it's very unlikely that they would describe it in the setting of a rose gardener or this specific fungal history or give us like evidence of a KOH prep. Lastly, let's talk about mucormycosis. And before we get started, I want to highlight some really hot buzzword for you guys. So this is going to involve necrosis of the nares and palate. It's going to be due to mucor and rhizopus species of fungus, and it is also going to be associated with people with diabetes, especially DKA. These are the hot parts of this disease process. Now let's fill in the details. So classically, this necrosis over the nose area, which you can see demonstrated here, is going to be associated with a black eschar. And it's also going to have these like really intense destruction of the nasal palate and the bone and the cartilaginous features that you can appreciate on CT. So if we look here in CT, we see this big lake of inflammation and destruction from this mucor infection. Super important. It's going to present as headache and sinus pressure, as well as these skin findings, this purple black eschar over the nasal bridge area, and is also going to almost always be mentioned some type of immunocompromised status. So that's either going to be DKA, some sort of HIV/AIDS, or some sort of trauma or burn to this area here. In terms of our management, this is an emergent condition. This is a very scary disease process because the mucor can actually spread from the nasal bridge into the brain and into the carotids and kill someone very quickly. So these patients automatically get amphotericin B and surgical debridement in order to treat this disease process. In terms of our differential here, pretty much the differential is going to be sinusitis, but this is going to be a much milder presentation. It's not going to have this erosive destruction or black eschar like we're going to see in mucormycosis infections. Additionally, one thing that questions might try to trip you up on or give you a clue is what this looks like under microscopy. So these are described as non-septate hyphae with wide angle branching. And the wide angle essentially means that these fungi branch at a 90-degree angle. And you can kind of appreciate the 90-degree angles that I drew here, as opposed to other fungi which might grow with a much narrower acute angle growth pattern. So that's another thing to be look out so you can nail this on test day. And that is it, guys, for our video on fungal infectious conditions. I hope you enjoyed it. Remember, the best way to do well in step 1 is to stay busy. I will catch you guys in the next video. Bye!